Hi. We had the recent discussion on congenital thyroid problems, where in brief we discussed the importance of newborn screening, why the newborn screening is important to pick up the hypothyroidism early so that treatment can be started before any injury to the brain happens. So there have been many questions on this topic, and I thought I'll do a quick video on thyroid concerns in the neonatal period, focusing on congenital hypothyroidism and the results of the newborn screen, how to handle it, and so on. So we will look at the thyroid physiology, an overview of newborn screening, hypothyroidism and hyperthyrotropinemia, which is quite commonly seen and causes confusion, where the thyroid, the TSH level is slightly on the higher side, so clinicians are wondering whether to treat it or not. And other causes like Graves' disease, which is cause of hyperthyroidism. So the thyroid gland develops from the foramen cecum, from the foregut endoderm, and it starts developing at the base of the tongue. So we do have ectopic thyroid in some cases where a remnant of the thyroid or even the full thyroid stays at the posterior part of the mouth. You can see it as a swelling in the back of the throat. It can sometimes be lower down as a swelling in the neck. So that is ectopic thyroid gland. Sometimes it functions normally, or it may not be fully developed, and it may be a cause of hypothyroidism. The development of the thyroid gland is mostly complete by 10 to 12 weeks of pregnancy, and the fetal thyroid actually starts concentrating iodine, indicating the start of the hormone production by 12 weeks. The maternal thyroid hormone crosses the placenta, so even if the fetus is not producing the thyroid hormone adequately, the fetus is protected against damage to the brain. The hypothalamic pituitary thyroid axis is established at 18 weeks. So the feedback regulation starts even during the pregnancy. So the hormone is produced mainly by action of iodine with thyroglobulin with different enzymes. So there is oxidation and organification of iodine by thyroid peroxidase enzyme. So monoiodine, diiodothyroid, thyronin are formed in the thyroglobulin molecule. And then the thyroid peroxidase results in combining these in different ratios. So 2-diiodothyronin will form thyroxine T4, and 1-diiodone, 1-monoido will become T3. You also have reverse T3, which is structural isomer of T3, and you can have reversal of this process, monodeiodination, 5-monodeiodination, which leads to either T3 formation or reverse T3, depending on the type of monodeiodinase that's acting. So T3 is an active form, however, it's very variable, and so measurements of free T3 are not very reliable in terms of monitoring hypothyroidism. So the two main tests we do are TSH, thyroid stimulating hormone, and T4. And remember that TSH is produced in the pituitary. So if there is a central cause of hypothyroidism, TSH is not increased, it's actually suppressed. And the T4 tends to be low in these cases. So the maternal T4, as we discussed, crosses the placenta. The T3 level is low until 30 weeks. After 30 weeks, the serum T3 starts increasing. So you can see that here that the T3 is quite low during the gestation. After 35-36 weeks, it starts going up. The reverse T3, on the contrary, is high during the gestation and comes down after birth. So in premature babies, reverse T3 may be high. And the T4, we have the range, and there is a surge after birth, which starts coming down after 4 to 6 days. There is an acute TSH surge after birth as well, which we will see next. So the surge happens in the first few hours of life for TSH, and it can reach as high as 70 milliunits at 30 minutes. It drops quickly, however, by 1 to 2 days. Most of the time it's normal. So the centers which use TSH for newborn screen can do it after 24 to 36 hours without having too many false positives. That has been my experience as well. And the labs do have differential cutoffs depending on the age of the sample. So they have a different cutoff of more than 15 at up to 3 days, and say 10 after 3 days, depending on the lab we are using and their cutoffs. The neonatal T4 and T3 peak at 2 to 3 days and then start reducing. So don't measure the free T4 very early, it tends to be high. And there is a higher T3 postnatally due to increased T4 to T3 conversion by the type 1 monodeiodinase. So this is the TSH surge, which is much briefer than the T4 surge. The TSH surge is the reason for the T4 to go up. Then it stays high for 2 to 3 days, and then by 5 days it starts reducing back. The TSH surge starts reducing quite earlier, so by 24 hours the surge is almost over. So if you have a differential cutoff, you can do the newborn screen by 24 to 36 hours. So the incidence of congenital hypothyroidism is not very uncommon. So 1 in 3 to 1 in 4,000. So the impact of congenital hypothyroidism on lifelong brain development is huge, and that's why it's no longer acceptable if we don't screen for congenital hypothyroidism, even in the resource limited settings. So the governments have a responsibility, the public has to be educated, the pediatricians all over the world have to be educated to make sure that we don't miss congenital hypothyroidism. We talk so much about birth asphyxia and therapeutic hypothermia and so on. Of course, better obstetric care, better availability of resuscitation facilities at birth are important, but this is equally important. So there is a female predominance, and the babies are often asymptomatic at birth due to the maternal thyroxine transfer. The incidence of hyperthyrotropinemia is relatively less reported, so 1 in 17,000 or 1 in 8,260, depending on which source you're looking at. So the most common reason for thyroid disorders, congenital hypothyroidism, is dysgenesis of the thyroid gland. So it can be ectopic in 1 in 5,000 and total absence of the gland in 1 in 15,000. Hypoplasia can be there in any of these as well. So if there is total absence, it's obviously shown to have a poorer prognosis, and the thyroxine, the TSH tends to be very high, the T4 tends to be quite low. While in ectopic glands, the TSH tends to be like 40 to 60 or 100, and the T4 is not too far from the range. Dyshormonogenesis is less common. You may have a family history, you may have a goiter, and obviously the newborn screen may not pick it up if the dyshormonogenesis manifests after birth. The goiter may be the first presentation, or the baby may be symptomatic. So keep your eyes open for both central hypothyroidism and dyshormonogenesis, which may be missed in the newborn screen. So we have different causes: the Pendred syndrome associated with deafness and goiter, thyroid peroxidase deficiency, thyroglobulin deficiency, deiodinase deficiency, and so on. So the central hypothyroidism is less common, 1 in 21,000. I'll have a presentation later on central hypothyroidism and hypopituitarism, which is an interesting case as well. So we may have isolated TSH deficiency, and you may also have multiple hormone deficiencies with hypopituitarism, micropenis, and so on. So keep your eyes open for micropenis, hypoglycemia, central facial defects, and so on. Resistance to TSH binding or signaling. So you may have a TSH receptor defect or G protein defect. Postnatal perinatal illness like hypoxia, sepsis, exchange transfusion, iodine exposure, these also cause hypothyroidism. So in central hypothyroidism, T4 is low, normal, and TSH is low or normal. So the T4 being low with the normal TSH suggests central hypothyroidism. And suspect in infants with cholestasis or jaundice which doesn't continue to improve. Babies have poor growth, there may be hypoglycemia if there is hypopituitarism, and you may have structural nervous system problems. Holoprosencephaly can be a feature on cranial ultrasound. You may have optic disc dysplasias as well, and other features of pituitary insufficiency. So the newborn screening is a very important tool, and hypothyroidism and phenylketonuria are the two primary diseases that were screened, and subsequently multiple conditions have been added. We nearly have 40 to 50 conditions now. So early diagnosis and treatment ameliorate severe cognitive problems in congenital hypothyroidism. This is beyond doubt. Earlier we diagnose, the better. So the newborn screen should be done ideally before the patient goes home. The vaginal delivery patients often go home by 24 to 36 hours. So to avoid missing out, we send the sample early, even though there is a slight increase in the false positive. But with the cutoff in the lab changing, we are not seeing that issue. And the heel prick test is done by day 3 to 5 or even earlier, as I discussed. And it's based on identifying TSH level elevation on whole blood on a filter paper card. So all of you would be familiar with the filter paper test. Wherever you work, you should be able to link up with the lab in the region. You just need a system to collect the samples and send it together. Even if you're in a remote setting, the labs can support you by coming, and courier can help you with that as well. So where there is a will, there is a way. So don't blame the system. Try to find a way in which your deliveries, the babies you deliver, can have newborn screening. And because the labs do it on multiple samples, you can have it fairly cheap as well. You can negotiate a good rate depending on the number of cases you have. The TSH threshold of 10 units is used mostly, but if your lab is sending samples earlier, you can have a higher cutoff for the first 3-day sample. So the age of the sample is very important as well. So most of the newborn screening in different countries have a primary TSH with backup of T4, which can be screened if TSH comes abnormal. This option is not available in all the labs, so be familiar with what your lab has. There can be false negative newborn screening in central hypothyroidism, as we discussed, and there can be a delayed TSH elevation in hypothyroxanemia, low birth weight babies, thyroid binding globulin deficiency. So you cannot be sure that you picked up these. So if there is a clinical concern like prolonged jaundice, you still need to do the full thyroid function test, even if the TSH was normal on the newborn screen. Some countries have primary T4 with a backup TSH. Here we can identify thyroid binding globulin deficiency, central hypothyroidism, hypo and hyperthyroxanemia as well. However, it misses compensated hypothyroidism, where the TSH may be high, but the thyroid gland is working harder to produce a T4, which is in the normal range. And the patients who have initial normal T4 and delayed TSH increase, as well as transient hyperthyrotropinemia, may be missed. Combined primary TSH plus T4 is ideal but not practical due to the cost implications, so most labs use primary TSH in the newborn screen. You may have a false negative screen if the sample is insufficient or inadequate, especially the spot sample if it's not dried and stored properly. Prematurity is one of the reasons where immaturity of the pituitary axis may cause acute illness. Exposure to iodine-containing compounds is more common. However, most of the NICUs have moved away from using betadine for premature babies, and preoperative preparation as well. We don't use betadine in premature babies. So there can be a delayed postnatal elevation in TSH, and blood transfusion can be a factor as well. So ideally, the newborn screening sample should be taken before blood transfusion, and if your baby is on TPN, you take a 0 sample, and then after the TPN finishes in a premature baby, you repeat the sample. False positive screening can happen if sampling is too early because of the TSH surge. If the blood spot is multi-layered, it can cause problems, and transient hypothyroidism can be there due to prematurity, due to the immature thyroid function, acute illness, use of drugs. Maternal antibodies can stimulate the thyroid, and maternal iodine supplements can impact as well. And as I said, iodine-containing compounds can also cause increased production. And maternal iodine deficiency can stimulate the fetal thyroid gland as well. So in terms of abnormal newborn screen, so if the level is more than 40, start treatment soon after obtaining the venous sample. In real life, sample and the result mostly available on the same day, so in most cases you can wait for the result, but remember that it's very urgent, and picking up the result, contacting the patient and responding immediately is very important. Every hospital should have a system where the newborn screen gets fed back, and there shouldn't be even a day's delay in reporting the results. So you should have a system over the weekend. You should have a system apart from the named consultant. Who else will get the report if a consultant is on leave? An email system involving the full team is a good option, but email alone is not enough. It should be a critical report from the lab so that the team is alerted and immediate action is taken. And parents also have a responsibility in giving alternative contact number or email options and so on. So sometimes a mother is too tired after the delivery, she doesn't pick up in the first 3-4 days, so dad's number is essential. So think about these aspects as well, so we don't delay any case. And once the thyroid is confirmed as abnormal, treatment is started, then you confirm by radioisotope scanning or scintigraphy. This is not in all the guidelines. Ultrasound is suggested in all guidelines, but you may miss ectopic thyroid or a small focus of functioning thyroid on ultrasound. So radioisotope scanning can be considered before the treatment is well established, so within 5 days or so after starting treatment, but don't delay initiation of treatment for imaging purpose. So if the TSH is less than 6, it's normal and no need to treat. And remember that in babies, in the initial days, there is a surge, and 6 to 20 is not very abnormal. So if the baby is more than 21 days, then you start investigate, and if it's free T4 is normal, you consider withholding treatment for 2 weeks and then retesting. So if it is 6 to 20, most of the time we repeat by 10 to 14 days, and if it's improving, we don't need to worry. If it's worsening, you start treatment. And if you happen to do it by 21 days, even with the normal newborn screen less than 6, then you may consider treating them as well. If it is more than 20, it's preferable to commence treatment even if the free T4 is normal. However, if it is trending down, you can wait a week or so if the T4 is normal. So this is the part that we will discuss later as hyperthyrotropinemia, where it's not clear cut whether to treat immediately or not. So the signs and symptoms at birth, they are usually asymptomatic. Baby may have post-maturity or macrosomia, the posterior fontanelle being open, a large head circumference, presence of goiter is only in the dysharmonogenesis. In the neonatal period, if it is not picked up and treated, baby may have decreased muscle tone, lethargy, poor feeding, hoarse cry, hypothermia. Prolonged jaundice can be seen both in hypopituitarism and hypothyroidism. Baby may have dry and mottled skin. The tongue thrusting out is a later sign, and many parents are worried because the tongue is prominent. Many babies have a tendency to have mouth open or push the tongue out, which is normal. So if the newborn screening is normal and baby is otherwise developing well, we don't need to worry. And abdominal distension, constipation, umbilical hernia may develop. Hopefully we don't see any symptomatic baby because the newborn screen should pick up and we should be able to avoid this complication. So this is how a baby looks, almost normal at birth, but if you don't treat, you get the typical hypothyroid appearance, a large tongue, coarse face, abdominal distension, umbilical hernia, and so on. Doing an X-ray to see the femoral epiphysis is not done much these days. Levothyroxine, L-troxin, thyronome, these are the different names, and initial dose is 10 to 15, it should be microgram per kilogram per day, and treatment should be initiated at the earliest no later than 2 weeks or immediately after confirming tests. The better outcome is seen with high dose early treatment compared to early low dose and late high dose. So I tend to start with 15 microgram per kilogram, repeat after 2 weeks, and then we can reduce the dose. So especially if you have started treatment with a high TSH, better to err on the side of caution and go higher. For example, if it's a 3 kilo baby, you can give 50 microgram, which is just above 15 microgram per kilogram. And for a 2 kilo baby, you give 30 microgram and so on. So the tablet comes in 50 microgram and 100, and you can dose it mixing it in 5 ml and spreading according to the dose you need. The tablet is crushed and suspended in a few ml of water or milk. Avoid concomitant intake of soya, iron, calcium, fiber. In newborns, this usually doesn't apply. We say pre-feed or 1 hour after the feed so that the interference with the calcium is less. Adjust the dose to ensure normal growth and development. Aim for a low normal TSH of 0.5 to 2 units and free T4 in the upper half of the reference range. And aim to normalize T4 within 2 weeks and TSH within 1 month. So you don't need to be worried if the TSH is coming down slowly, but as I said, err on the side of caution and start at the higher end of this range. I'm seeing many patients reporting that in the newborn with the TSH of 100, they are started on 25 microgram. It's not wrong, but it's preferable to start them at least with 37.5 microgram for a 2.5 kilo baby or so, and 50 microgram for 3+ kilo baby. And then you are going to repeat after 10 to 14 days anyway, so you can titrate it down. The impact of high dose is going to happen in the long term. If the baby is hypothyroid, a small difference, a small rise in the dose doesn't impact the bone fusion and so on. So these effects are the ones we are monitoring, the higher T4 levels to be avoided. So you don't need to panic when you're monitoring closely. And education of the family is very important when you start treatment. Explain to them that it's an impact on the brain development, so you cannot take it lightly, and you have to be very clear about why you're starting, why they shouldn't miss a day's dose. If they do forget the dose for any reason, they can give it later in the day. And it's also important to tell them to come for the blood test before that day's dose is taken, so it doesn't interfere with the free T4 levels. They should remember to take it soon after the sample is taken, so that is important as well. Many parents are worried about the instruction about feeding on empty stomach in a newborn or in the first 2-3 months, babies keep feeding all the time. So the best advice is to give 1 hour after the feed so that you don't miss out on the dose as well, waiting for a pre-feed. And in transient congenital hypothyroidism, 10% of the cases can be identified as transient. So most of these babies are already on treatment. As we discussed, we don't want to delay treatment. And when you want to review this is around 2 to 3 years, unless the free T4 consistently comes high and the TSH is very suppressed, in which case we keep reducing the dose. Sometimes we go to even alternate day dose and keep them on a very low dose till they are 2 years. Then we stop treatment for a few days and then repeat the test to confirm if they can stop. Even in that case, we have to continue monitoring a few monthly till they are older. And the causes can be multifactorial. We have genetic and environmental conditions. Perinatal goitrogens can be a factor, maternal antithyroid drugs, and endemic iodine deficiency can be a factor as well. So hyperthyrotropinemia is where the TSH is mildly increased and it stays on the higher side. It's often confusing in these cases what to do. There are a few studies which have looked at outcome in such babies, and a higher proportion of babies with this condition have clinical hypothyroidism later on. And developmental assessment of these babies has shown that if the TSH tends to be high for a longer time, the development may be slightly different on the lower side in IQ range compared to the normal baby. So this is something we need to watch carefully, and so we shouldn't ignore it. At the same time, the difference is not very huge, so we should be careful about over treating as well. So it can be related to congenital developmental anomalies like hemiagenesis or hypoplasia, where the thyroid is compensating. So this is subclinical hypothyroidism. You may have congenital conditions like Down syndrome or Williams syndrome, and it may be an SGA baby. You may have mutations in the proteins involved in TSH action, TSH receptor, and thyroid peroxidase mutations. And subclinical hypothyroidism may develop later also. So if you have identified it, you monitor these children even if you don't start treatment once in 3 months or so. So investigate the causative factors. Consider treatment if TSH remains persistently above 20, for example, even if the T4 is normal, especially if the T4 is on the lower side. The AAP guideline defines treatment for all babies with TSH persistently over 10 after the first 2 weeks. So this is an option as well. But if you are planning to repeat after 7 to 10 days in these babies to see the trend, that is acceptable as well. However, if it is persistently abnormal beyond 21 days to beyond that stage, you would start treatment. If not treated, the free T4 and TSH should be repeated in 2 to 4 weeks, and treatment should be initiated promptly if they have not normalized. So there is no consensus on treatment between 6 and 10, and I personally don't treat these babies. I keep an eye on these levels. So this is a case which is not hypothyroidism, hyperthyroidism. So we have a 3-day-old male, normal delivery, 2.9 kilo, mother is primigravida. Baby is day 3, not feeding. There is intermittent tachycardia going up to 210. The mother had hypothyroidism on thyroxine. However, it's very important to note the history of previous treatment. Many times we think that there is hypothyroidism, but she might have had a gland removed for Graves' disease, or she may have had a radioiodine ablation. So this past history is very important, and this is the only group where if the mother has hypothyroidism on L-troxin, you would definitely test the thyroid function in the newborn. Otherwise, you can wait for the newborn screening results in the other cases. So where the mother is hypothyroid, if the past history of hyperthyroidism or she is currently hyperthyroid, you need to test the baby's thyroid function by 2 to 3 days, even if baby is asymptomatic. This is because the thyroid receptor antibodies, both stimulating or suppressing antibodies can be there. And if there are stimulating antibodies, you get neonatal thyrotoxicosis. So neonatal Graves disease is where the maternal antibodies are crossed over from the placenta, and it's transient Graves disease. 1.5 to 2.5% of the babies born to mothers with a history of Graves disease. So the baby may have tachycardia, heart failure, non-immune hydrops, IUGR, increased skeletal maturation, craniostenosis if you're not treating it. And symptomatic cases may be treated by maternal antithyroid drugs. So remember, this percentage is not of the population, it's of the mothers with Graves disease. So prematurity, low birth weight, poor weight gain, weight loss, feeding difficulties, and goiter may be there. Baby is irritable, restless, hyperthermia may be there, flushing, tachycardia, cardiomegaly, heart failure in the severe cases. Lid retraction develops later, proptosis, periorbital edema. Diarrhea may be there as a manifestation of increased GI motility and frequent stooling. Tachycardia, heart failure, hypertension, hepatosplenomegaly, cholestasis, and thrombocytopenia. So measure the thyroid function at 3 to 5 days. If it's normal, repeat at 10 to 14 days. And if it is no normal, even then you can stop testing, because the antibodies half-life keeps dropping, and so it's not going to manifest after that. By 4 weeks, 2 months, and 3 months, assess clinically. If there is a delayed presentation, baby may develop hyperthyroidism as well, autoimmune. If the babies born to untreated mothers are diagnosed at day 1 to 3, while those born to mothers treated with antithyroid drugs are diagnosed between day 7 to 17. So this 10 to 14 day screen will pick those up. The babies may require a beta blocker if there is cardiac side effects, and propranolol can be used to control the symptoms. Watch for hypotension and hypoglycemia. Carbimazole, of course, is a treatment of choice, and it can be used 3 times a day at this dose. As this carbimazole treatment can take 24 to 48 hours to have effect, you may consider a blocking hormone release with Lugol's iodine, 1 drop 3 times a day. And corticosteroids, if symptoms are severe, may help along with the propranolol. Sedatives may be used if the baby is very irritable, and we have to adjust to keep the free T4 and TSH in the normal range. Avoid over-treatment and drug-induced hypothyroidism. So we have to monitor the thyroid function. In some babies, we may need to supplement L-troxin as we do in the mother. Thyrotoxicosis remits after 8 to 20 weeks, and nearly all babies are euthyroid by 48 weeks. So to conclude, neonatal screening to pick up hypothyroidism is very important. The effort to implement screening in resource-poor settings. So national bodies as well as the local groups should discuss to make it easier, facilitate support with each other. The bigger groups can negotiate better rates. Regional labs, actually even in UAE, for example, most of the labs are outsourced to Indian labs in Bangalore or Bombay, for example. So it shouldn't be difficult in setups like that. And given the importance, the government should support this program. So IAP, NNF, and other bodies in different countries can take this up to make sure that all babies get newborn screening. If results of the thyroid function is borderline, monitor at regular intervals and involve the endocrinologist appropriately. Remember that this presentation is not to remove the role of the endocrinologist. It's for you to be aware of what to do. And because I see many questions from parents and borderline hypothyroidism, what to do, borderline results on the newborn screen, what to do, and so on, I have done this presentation. So I hope this is useful, and please do share. Thank you.